Welcome to the latest in our We Are Gaucher webinar series. International Gaucher Day 2020 is on the 1st of October. This important day of the year is an opportunity to shine a spotlight for the Gaucher community, celebrate its achievements, and tell the stories of those affected by this disease around the world. Before this day, we have been hosting several webinars as part of our series, and we are happy that you have decided to join the conversation. Today, we welcome Dr. Cheema, Cheema, Head of Pediatric Gastroenterology Department at Children's Hospital of Lahore, and Tanya Collin-Histed, Chief Executive Officer at the International Gaucher Alliance. We will discuss the quality of life of patients with Gaucher disease and touch on the following subjects: complications, comorbidities, and lifespan of patients with Gaucher disease, the quality of life as a therapeutic goal of patients with Gaucher disease, measurements tools for Gaucher disease, and the influence of fatigue in the quality of life of patients with Gaucher disease. If you have any questions, please enter them into the Q&A chat, and we will come back to them at the end of presentation. Now let's start what I think it will be a very informational webinar as we work together to transform healthcare for Gaucher. Dr. Cheema, the stage is yours.
Hello, it's a good afternoon there, I suppose. It's a good evening here in Pakistan. Talking about Gaucher disease today, and Gaucher disease, as we all know, it's a common lysosomal storage disorder and autosomal recessive storage disorder. This is due to a deficiency of acid beta glucosidase, and the complications which happen are from the accumulation of the glucosal ceramide within the lysosomes of tissue macrophages. So these engorged macrophages are basically the Gaucher cells which produce all the problems. It's a progressive, chronic, heterogeneous, multisystem, debilitating, and life-threatening disease. Now, the prevalence in Pakistan is not that much known. We are working on the figures, and we have the national data now to work on the figures, but the worldwide overall is probably it's very variable. So it's 1 to 100,000, or between, in the Ashkenazi Jew population, it is way higher. The common mutations are the 370S, the L444P, the 84GG. The phenotype-genotype correlations, as you're aware, there is not much of, sometimes there is a huge variability, and the genotype does not exactly predict disease. I just started with a few introductory slides so that just to get on to the topic, which is mainly going to be about the complications and the comorbidities. And the L444P, which is very common in Pakistan, it predicts the chronic neuronopathic type. Gaucher disease, as we said, is a progressive, multisystemic, multi-organ dysfunction is caused by it. These substrate engorged macrophages, which are the Gaucher cells, they accumulate in the viscera, causing the splenomegaly, hepatomegaly. They infiltrate the bone marrow, they cause hypersplanism, so there is thrombocytopenia, there's anemia. As they infiltrate the bone pain and the bone crisis, the osteoporosis, the fractures, that's a major, major morbidity of Gaucher disease. In fact, some say you can consider Gaucher as mainly a disease of the bone. And many other organs, including the lungs, the brain, they're affected. Even mild disease, the 370S in adults, can cause significantly decreased quality of life. Looking at the phenotypes, now, I'm mainly going to be talking about the type 1 and the type 3, but there are 3 types. The non-neuronopathic is the type 1, and the 2 neuronopathic are the 2 and 3. Type 2 is the acute neuronopathic, and type 3 is the chronic neuronopathic. And the visceromegaly can be from mild to severe in all types, but the neuronal presentation is absent in the type 1. And this really depends on your genotypes mainly. Now, presentation in children is is pretty, as you can imagine, any disease which comes on in pediatrics, it comes on earlier than adult life, is going to be more severe. And it is severer in certain mutations like L44P, which have very early manifestations. Children will have marked splenomegaly, they can have bruising, bleeding. The other thing about, they will have hepatomegaly, splenomegaly, anemia, thrombocytopenia, growth retardation, bone disease, bone pains. Now, looking at the presentation of the patients, about 172 patients of Gaucher disease in Pakistan, the main way that they presented, because they were coming early, our most common genotype, as I said, is L444P, is hepatosplenomegaly and anemia or bleeding complications. Also, one very important factor in these patients with early presentations is this hypermetabolic state that they have. And they have failure to thrive, fatigue and weakness, not only from the anemia, but the general hypermetabolic and the cachexic state that they have, lung complications, need for repeated transfusions. And if you look at type 2, we are not really discussing, which is the main acute neurological manifestations are there. But the type 3, now type 3 has been divided also into 3A, B, C. The 3A would have the myoclonic epilepsy and dementia, and the horizontal saccadic abnormalities, strabismus and early severe disease with even significant visceromegaly and hematological manifestations are more in type 3B. Cardiac valve calcifications, this is a very peculiar type of Gaucher, which is type 3C. Pulmonary disease in any one of these can be relentless. If you look at the type 3B, which is very common in Pakistan, early presentation, all these, most of our patients are less than 6 years of age. If you can see that squint, that horizontal, the convergent squint in these patients, which is an early sign. And the one patient on the bottom right corner, you can see had a relentless, severe presentation with myoclonic epilepsy. Now, Gaucher disease will shorten the life expectancy of a patient without treatment significantly, and even with treatment might not have the same lifespan. So not only that the quality of life, but the total number of years is affected. For patients with type 1, the life expectancy at birth, you can say, is decreased by about 9 years. The diagnosis is simple and straightforward. With a dried blood spot, you can measure the enzyme or go ahead with the DNA analysis. But why is it that the diagnosis is frequently delayed, both in type 1 and in type 3? The diagnosis of type 1 can be delayed for many, many years. Type 3 frequently comes to us as well, even though they have massive organs and early presentation. Still the delay of about a year and a half or sometimes 2 years is there. But in type 1, up to 4 to 10 years of delays is talked about. Almost all over the world, there is a frequent delay in diagnosis. And there is a confusion with either malignancy or with lymphomas in bleeding disorders, and in children with hemolytic anemias. In developing countries like Pakistan, it might be considered malaria, disseminated TB, leishmania, but there are huge deleterious consequences to delayed diagnosis. You can have pathological bone fractures, progressive liver disease, growth retardation, life-threatening bleeding, and the discomfort and the disability due to the bone disease, it will impact the quality of life in a child. And as you can see, the bone disease is extremely common in Gaucher, and in 83% of patients will have some evidence of radiological evidence of bone disease. Some 7% would have bone crisis, and 34% would complain of bone pains. So the pathological event which happens, the infarctions which cause the bone crisis or osteonecrosis, and the failed linear bone growth will cause a short stature. And the pathological changes that you see in the bone are hemorrhagic infarction, necrosis, osteosclerosis. And this osteosclerosis and the loss of cortical bone will cause the Eiler-Meyer the typical Ireland-Mayer class deformity. Now, there is a huge challenge of skeletal pathology in Gaucher that it's often not properly assessed, monitored, and not properly treated. The challenge always is how best to detect it, how best to monitor and treat this potentially reversible disease, and at the same time prevent irreversible complications. Looking at the disease complications, complications of Gaucher will depend on genotype, the age at which they come, presence or absence of spleen. Now, what does that mean? That means if they have undergone a splenectomy, which shouldn't be happening, but it still happens in a lot of parts of the world, that if because of the massive organomegaly, the patient undergoes a splenectomy, some diagnosed, some undiagnosed. It also, the complications will depend on whether the patient had access to enzyme replacement. A lot of patients in Pakistan, for instance, there's an unmet need, have no access to enzyme replacement. And then again, when was an enzyme initiated? Many of the patients in developing countries have a delay in diagnosis, or they don't have access to treatment, and there is, by the time they have approval of any charitable access treatment, they're pretty sick and morbid. So course of Gaucher disease is very variable. And even in the same family, two children will not behave in the same way. It ranges from the minimal kind of a symptomatic presentation to severe and debilitating symptoms. They can have massive organomegaly. Patient can come with significant bleeding, failure to thrive, delayed puberty, the bone pains and the bone infarctions, which they will cause damage to the joints, and you can have hip joint, shoulder joint pain. The osteoporosis of the bones will cause weakness and bone pains. And you can have fractures, spontaneous fractures. Now, treatment, enzyme replacement for Gaucher disease improves the visceral and the hematological parameters. So you can see that as you initiate the enzyme replacement, the platelet count, the hemoglobin, the liver size, the spleen size all gets better, and bone mineral density gets better. But, and you can see the impact of ERT clearly in this patient who had these massive organs and failure to thrive. And you can see the same child who has no abdominal distension, growing well and looking fairly happy. And the same a happy school-going kid now who had a massive visceromegaly. So you can clearly see the impact of enzyme replacement in these children. But then this is what happens. This is fate without treatment as well. This is the early and severe presentation, delayed diagnosis. Unfortunately, such a patient is likely to not make it. And this child arrived in the emergency room with a platelet count of 6,000. Again, pulmonary disease, the complication of pulmonary disease is significant, particularly in Gaucher disease type 3. Now you can see that this child who has a convergent squint, despite being on enzyme replacement, died out of a pulmonary hemorrhage, and the lung X-ray shows significant lung involvement. Now, whether the question always is whether you start the enzyme replacement very early, is it going to prevent this complication of pulmonary disease? We have seen that in siblings when one of the children who had died, for instance, the little brother of this child, we started therapy early, does not have any pulmonary disease. We don't know whether this is just that he doesn't have it or is because of early initiation of treatment. Now, neurological complications, they are quite problematic. Now, this child is on enzyme replacement, but he has myoclonic epilepsy, significant cognitive decline, strabismus. Patients can have spasticity. Now, this is something where enzyme replacement in GD3 is not really making any difference. And whether we should be continuing it or not is another question, though the visceral parameters are definitely better in this patient. Coming to some other complications which are not very common, we see cardiac valve complications, and this occurs in patients who harbor the homozygous missense variant, the D409H in the GBA gene. And you can see in this patient, there is aortic root calcifications, and they also have neurological manifestations. So it's not just one genetic, I think it's not just D4 or 9H alone, but there are other genetic and maybe environmental modifiers that play a role in this final encountered phenotype in these patients, which we call GD3C. This is one of our patients who is this younger sibling of another patient of Gaucher disease who's doing very well on enzyme replacement. But this younger sibling bled massively and on endoscopy had a lot of Gaucheromas in the stomach. So Gaucheromas and can happen not only in the GIT, in the various organs, and the same thing is the abdominal lymph nodes in the Gaucher disease. Now, we have a few patients. We have two patients, one of them who does not have neurological manifestations but has lymphadenopathy in the abdomen, and another one who has neurological disease as well as abdominal lymphadenopathy on the CT scan. Now, you can see this lymph nodes here, which are calcified. They're merging around one of the, if you look closely, both the thick and the thin arrows will show how all the clump of lymph nodes over there, and there is calcification. Now, not only that they cause abdominal pain, they can cause obstruction to the lymphatic drainage and a protein losing kind of an enteropathy. Frequently, like one of our patients has kind of had a mild protein losing enteropathy but got better, and most commonly you don't have to go into resection of these lymph nodes. The important thing is to differentiate it from a lymphoma or a malignancy, because as we know that, and we'll come to it, they're more liable to develop these malignancies as well. So it's important that we differentiate this is relatively benign condition from the malignancy that they can have actual. The other big comorbidity or complication that they have is the significant cachexia and the failure to thrive, as you can see in this patient. Unfortunately, this patient came late, and even the 2 months of enzyme replacement that we did give him, he could not make it. This hypermetabolic state that he had, and severe failure to thrive, did not improve dramatically with 6 to 8 weeks of therapy, and probably he was a bit late in that. And then bleeding complications. Now, this little child, 2 years old, just 3 weeks back diagnosed, and came in with a profuse bleed, massive organs, spleen 17 centimeters, and platelets of 12,000. The problem with these patients is you infuse platelets and the platelets disappear within hours. It's always a challenge to treat them, to raise the plate, do their platelet function studies, get platelets, mega units into them, and try to do an emergency splenectomy. They just don't stop bleeding. And this 7.5-year-old boy came to us with abdominal distension and pallor, and the history that he was treated as thalassemia in another city. On a poor response, he underwent a splenectomy. 3 years later, he developed severe pain in his left leg and he couldn't walk, and that was his X-ray. Well, at that time also, unfortunately, he wasn't immediately referred. He was treated as osteomyelitis, and since he didn't improve, then again underwent a surgical procedure, but finally referred to us because somebody did a liver biopsy and which showed foamy histiocytes. So it was a different way of diagnosing. Now, we started him on enzyme replacements, bisphosphonate and vitamin D, and he's since then been doing well. His follow-up X-ray and his bone scan, as you can see, is totally changed. So the enzyme replacement therapy for him proved to be very good and improved his health and quality of life. And you can see that how the best way to look at bone marrow infiltration with Gaucher is with an MRI, and you can see a normal on the left side versus infiltrated one on the extreme right. And you can also see that how it improves with therapy and the knees of the same patient after enzyme replacement versus before enzyme replacement. Now, not only that the bone function, improves, you induce catch-up growth with enzyme replacement in children. they reach their peak bone mass. It has dramatically reduced the incidence of osteomyelitis in Gaucher disease, and you have fewer surgical intervention required. So the therapeutic goal for skeletal pathology would be in pediatric patients to attain normal growth and maturation and have an ideal peak skeletal mass, increase the cortical and trabecular bone mineral density, and this would take at least 2 years. And in all patients, you want to lessen or eliminate the bone pain and prevent the bone crisis. Again, you need to have therapy for at least a year or 2 for that. And the key therapeutic goals for the hematological and the visceral would be that your hemoglobin stays more than 11 in females and more than 12 in males, and the platelets more than 120, the spleen volume less than 8, and the liver volume less than 1.5. And well, ERT in Gaucher, I would say that in type 3, there is no treatment for the neurological manifestations. And there is limited evidence that if we give them ERT, it would improve even the non-neurological in these patients. And you have seen in the patients in the pictures that I showed you that ERT sometimes makes no difference in them. And this is another patient of ours who has GD3, and despite being on ERT, has a lyso-Gb1 which is very high. And again, the question arises, should he be on the ERT? Is it making any difference? And the mortality of delayed treatment, as I said, no treatment or delayed treatment, both are bad. And these are the children out of which 2 of them did get some help but delayed, and the rest actually had consequences of no treatment. So these were the mortalities of early onset severe Gaucher disease signs and symptoms. If you look at the cause of death with us, and a large number of them are the bleeding. Failure to thrive seems to be a significant thing. Bleeding and infection risk, they keep coming back and forth. They have these immunological issues where they have frequent infections. One patient, unfortunately, when we were in our learning curve and we did a splenectomy without doing platelet function, unfortunately, we lost that patient. We also had 2 patients with liver cirrhosis. So looking at the quality of life in patients with Gaucher disease, most studies which have been done in adults. There are some studies also now in pediatric patients. And the adult studies also demonstrated that there is a huge positive role for symptom control by ERT in patients, and not doing a splenectomy is important. Splenectomized patients will obviously never have the same quality of life. Their fatigue and anemia or the other manifestations will always be worse. Non-treated patients in Pakistan, for example, will have very poor life quality with significant organomegaly, anemia, failure to thrive, recurrent infections. They have very frequent hospital admissions. Eduardo Remor and Spain, they undertook a multi-center study. They looked at the health-related quality of life in 20 families with Gaucher disease. And they found that experiencing bone pains, feeling fatigued, or generally feeling ill, which would put restrictions on playing and socializing or restrictions on physical activities, it affected their school or social performance. Feeling anxious on the day of treatment. Now, this is a huge thing. Nobody wants to be pricked so frequently, and any child, even an adult, would feel anxious. So feeling anxious on the day of treatment, the day they're going to get an infusion at the hospital, they also had lower scores on physical health, and they had lower scores on social functioning. The subjective feeling of being ill, of knowing that you're not really well and you have a disease, and anything which limits your daily activities, or feeling sad that you had a chronic disease, obviously they're associated with low HRQL. And this had a very adverse effect on social and school functioning. Patients' belief about treatment revealed sources of resilience. Now, If a patient believes that, or a child believes that, okay, I have a disease, but I am on treatment and this will protect me from getting ill or from having any problems, and that causes better emotional functioning. But I think that's where counseling comes in. That's where a good patient-physician interaction comes in. That's where patients or families getting together and talking comes in, and giving them good counseling. So quality of life and psychological functioning of pediatric and young adult patients was looked at by another group, and they said that younger patients with GD1 were more affected than older patients in the psychological domains. So it's probably very, very important that you implement any psychosocial intervention. It is more beneficial if it's done at an early age. So if the early childhood where the patients present, and if they have better counseling, they have better psychosocial intervention, they're likely to have better health-related quality of life indices. Now, the other last couple of slides are on the few other comorbidities in Gaucher disease. We talked about frank neurological signs, but there are neuropsychiatric disorders like depression and cognitive decline, which can happen in all Gaucher. There is a strong correlation of Gaucher gene and having Parkinsonism. Cardiac involvement, we spoke about the valves, but they can have cardiac failure, anemic cardiac failure, or hypertension, cardiomegaly. They also have hypermetabolic state, higher incidence of type 1, type 2 diabetes. There are immunological manifestations of, as I said, repeated infection. There is a higher prevalence of acute rheumatic fever, anaphylactic reactions, GI-wise atrophic gastritis, Meniere's disease. There is a close association between Gaucher and non-Hodgkin's B-cell lymphoma and myeloma. There are several possible explanations have been given for the increased B-cell proliferation. This would include the possible influence of sphingosine. This sphingosine is derived from the extra-lysosomal metabolism of glucosal ceramide. We also talk about gene modifiers. If patient has had a splenectomy, is more liable to have these problems. And there is a huge problem, as we talked about, the immune dysregulation and the hypermetabolic state induced by cytokines. And we talked about increased incidence of Parkinsonism. So in any patient of Gaucher, I think after doing the initial assessment, you establish appropriate therapeutic goals. You determine your therapy and the individual dosing. You assess the status of the patient by regular monitoring. You monitor for all the indices as we spoke about. We try to achieve the therapeutic goals in the required time. And if it isn't happening, then you must individualize the dosing, and you discuss as a multidisciplinary approach the therapeutic options in a case if the patient is not doing as expected. And again, it's very important to keep assessing the quality of life of the patient and how the parents and the child perceives it. In summary, Gaucher disease is a chronic, progressive, multisystem genetic disorder which affects multiple organ systems. Delay in diagnosis is not uncommon, particularly in developing countries, and has huge deleterious consequences. Enzyme replacement therapy does improve the quality of life in GD1, but some aspects of GD1 even then still might not be completely improved. There is no optimal therapy at the moment for GD3 and its related neurological complications and the comorbidities. Despite treatment, many patients may not have optimal health-related quality of life. There is a significant number of comorbidities, and we need more research and insight in dealing with these comorbidities, which we are still not totally clear about. And I think I will end here. Thank you so much. Jody, over to you.
Thank you, Dr. Cheema, for the very insightful presentation. Now let's continue with the presentation of Tanya, where she will introduce us to the measurements, tools, and the influence of fatigue in the quality of life of patients with Gaucher disease. Tanya, the floor is yours.
It's actually afternoon here in the UK, so hello to everybody. And I'd like to take the opportunity to say thank you to Centogene for inviting myself as a representative of the International Gaucher Alliance to talk today about the quality of life of patients with Gaucher disease. So here's my disclosures. So currently there are two measures of quality of life that are currently used in areas such as research, clinical care, clinical trials that we use. One is the SF36 and the other one is the EQ5D, which I'll show on the next slide. However, for Gaucher patients and their caregivers, it's really important not to look just at, clinical markers and results, but to look holistically at the patient in order to manage and understand them, to recognise the impact of the disease on patients' everyday life. And also to, obviously, one of the reasons that we use quality of life measures in clinics and clinical trials and research is to maybe understand the impact of treatment. But it's also very important to use tools for quality of life for clinicians and other people involved in their lives to really understand how best to support patients. And that could be accessing different types of support. So here on the screen is the current measurement tool for that's often used, which is the, as I say, it's the FF36, and it looks at lots of different domains, and it's a very generic measure. The next one is the EQ5D. Now this one is also generic, and it's used very often in clinical trials, but it's also more used in things like health technology when organisations are looking at the cost of treatment, and when they introduce things like quality of life years, etc. So they use this often to look at patient symptoms, and it's a very good tool. It's validated, and to compare the impact of disease across other diseases. So these are two that are used. But however, I think, however important it is to have these tools that are validated, they are generic. Yes, they provide some knowledge and understanding of disease, but they don't highlight things that are important to Gaucher patients and to their caregivers. So as an organisation and a patient community, we really want to move forward and sort of use measures that recognise important aspects of the disease, to our community. For instance, fatigue is a massive issue for the Gaucher community. And I think I found this as part of a publication from Orphanet entitled Rethinking Fatigue in Gaucher Disease. And I think it's what it says, if I give you a second or so to read the slide, is really important. And we hear this, fatigue is a really important issue and a symptom that we hear a lot about from our patients and their caregivers. And the impact of fatigue is huge, and can also have an impact on a lot of it has an impact on a lot of areas of a patient's life. So often they think about, you often think about fatigue as people feel tired, and then they think, well, you know, everybody feels tired. But I think fatigue in Gaucher disease is very, very different. Is it fatigue that is caused by disturbance of sleep? So why is there a disturbance of sleep? Could that be neurological? Could you get cognitive fatigue, and that can have an impact on your ability to work, or your ability to study? Can you get fatigue because you have bone pain, and therefore, you know, so I think fatigue is something that a lot of patients have issues with, but it's something that's not really understood. And it's very, very different to quantify when you talk to your doctor. I think, you know, current quality of life measures that we use in things like clinical routine, clinics, routine studies, research, clinical trials, they don't pick up things like this. And they don't allow for an analysis of the sort of other disease-specific issues, which can all be interrelated, as I said, about neurological bone pain. So they don't really give a very good true understanding of the impact of the disease and the burden on patients and families. And therefore, if you don't have all of the details about how this is all interlinked, then it's really difficult to treat. And I think that often, I've been in clinic with my own daughter who suffers from fatigue, and doctors are great, and they'll say, well, you know, you need to have more rest and you need to do more exercise. And of course, you know, these are really important things, but they don't get to the source of what the fatigue is. It's obviously something that's a big part of the condition and has a big impact on patients' everyday lives. So I think while there's a place for these validated generic quality of life measures, as a patient community, we want to take this forward, and we want to really understand the burden of the disease on our community. And we want to look at how the best way that is to capture that, so it's standardized and it's validated, so that it can be used, you know, in clinical trials and to get medicines, you know, through regulatory pathways. And what we want to do is we want to really understand the impact of patients, so that we can say, when they're developing treatments, what is it important to the patients? What do the patients want out of a treatment? So one of the things that is growing more and more recognition, particularly by the regulatory agencies, so like the FDA or the EMA, is what we call patient-reported outcomes. And this is like the real voice of the patient. And this is where you create a patient-reported outcome that's actually about the specific disease. And you can use validated measures such as the EQ5D and SF36, but then you use like specific disease questionnaires or a specific element. So that could be, you know, something like on this slide here, you can see we're talking about things like fatigue, talk about things like behavior. So you can develop your patient-reported outcome using validated tools, using questionnaires, but it's more designed to capture what's important to your patient community, that really reflects the burden of the disease, and can actually then, when you have a new treatment or you have a new care or support, it can actually show the impact on what's important to the patient. So as an organisation, I said to you that this is something that we are very keen on. We currently have a strategic plan, and we want to really, one of our goals is to develop patient-reported outcomes that can be used for patients with type 1. We're currently working with an organisation to do that. And although it's important to use patient-reported outcomes in things like clinical trials, it's also really important to use them in things like current clinical care. So when you routinely go and see your doctor, because it really shows your doctor about the different parts of the disease and what's impacting on you and how they can best support you. And that could be referring you to different types of support. As well as doing patient-reported outcomes for type 1. As an organisation, we are actually developing our own patient-reported outcome for neuropathic disease covering type 2 and type 3. And we're also going to be doing a caregiver-reported outcome. And you'll see on this slide some of the domains that we will be using. Now, the way that we've developed these patient-reported outcomes, we've actually used information that we gained from our own neuropathic global community on what the impact of the disease was on them. And we've worked with Professor Debbie Elstein, previously from the Sharik Zedek Institute in Israel, on that as well. And we're going to be capturing them through technology, through an app and through wearable technology. And we're going to be doing that through our new global patient registry, which is called Guardian, which stands for Gaucher Registry for the Development, Innovation and Analysis of Neuropathic Disease. So we're really, really excited about that. And that's going to be something that we want to really get out into our community, particularly in neuropathic disease, and Huma talked about this a lot. There are really not any really treatments that are effective for the neurological disease. When you develop a treatment, you need to know what your endpoints are. You need to know where the treatment needs to make a difference. We believe that by having patient-reported outcomes as well as clinical information, we'll get a much better understanding of the impact of treatment on things that are important to patients. So just to end and to summarize, I think, you know, for me, thinking about one of the slides I showed you about rethinking fatigue in Gaucher disease, you know, patients do give it's really important to patients the symptoms, not just about objective markers like how big is your liver or your spleen or what your blood count is, although that's really important. Actually, things like quality of life impact is so important to patients because it can really make a difference. So thank you.
Thank you, Tanya, for the very interesting presentation. Now we have only 2 minutes, so for this reason I will be very quick. Let's discuss one question from the audience, for example, to both. It's a question to both of you. Okay. So, what is the most important thing to improve the quality of life of patients with Gaucher disease? Professor Cheema, for example, could you start very briefly?
Most important thing to improve the quality of life? Yeah. I think that would be some form of treatment. Unless and until the patient or the family has a hope that there is treatment, their psychological profile is not going to improve. Then obviously treatment is going to impact on various other aspects. And then I would say next to that is a constant good physician patient or parent interactions, but some form of treatment is required to improve the quality of life.
Okay, thank you. Tanya, the same question, but how about the patients, for example, in developed countries that they have treatment? How is the most important thing to improve the quality of life of treating patients?
So I was So I was going to say treatment, and Huma said it, and then I was going to say a good physician, and Huma said it. So for me, I think one of the most important things in developed countries are things like patient organizations, having a good, strong patient organization who can support patients. Having a rare disease, it doesn't matter where you live in the world, can be very, very lonely, very isolating, and have a lot of psychological impact. So I think having good patient organizations where patients can talk to people like-minded, they believe they're not alone, and that patient organizations can then make huge difference. I think everything a patient organization does will improve the quality of life of the patient, whether that's information, holding their hand, being there to talk to somebody, fighting their corner, linking them up with other families.
Okay, thank you both for providing us with an in-depth look into the quality of life of patients with Gaucher disease. Thanks to all the participants for joining our We Are Gaucher webinar series, and we hope to see you out our next one tomorrow. We are also very welcome to join our International Gaucher Day digital conference that will take place on the 1st of October. The registration is open, and we look forward to seeing you there. Lastly, we are going to launch a poll allowing you to give feedback and enable us to further improve our educational webinars. And we would greatly appreciate if you could take a few minutes to fill it out. Once again, thank you and have a great day.
Thank you. Thank you. Have a great day.